There is something happening inside your body right now that you will not feel. Not today, probably not this month, possibly not for years, and yet it is happening with the same biological certainty as everything else your body does, quietly, incrementally, and entirely beneath the threshold of conscious awareness. Your liver, your kidneys, and your heart are three of the most resilient organs in human biology. They are built to absorb extraordinary amounts of stress before producing any signal you would recognize as alarming. And that resilience, remarkable as it is the precise reason that the most serious damage to these organs so consistently reaches an advanced and often irreversible stage before the person carrying it has any meaningful warning. Before we go any further, if this channel gives you the kind of honest, evidence-based clarity that is genuinely difficult to find elsewhere, please take a moment to like this video and subscribe. What I am going to walk you through today is how to tell specifically, practically, and with biological precision whether your liver, your kidneys, and your heart are already under the kind of stress that demands your attention. Not the dramatic signs that send people to emergency rooms, the earlier ones, the ones that are already present, the ones most people have been misreading or ignoring for months, sometimes years. Let us begin with the biological reality that makes this conversation necessary. Your liver can lose more than 60% of its functional capacity before a standard liver enzyme test is flagged as abnormal. Your kidneys can decline to less than half their peak filtration capacity before creatinine levels rise enough to prompt clinical concern. Your heart can be developing serious arterial disease for 2 to 3 decades without producing a single symptom that would make you reach for the phone and call your doctor. This is not a flaw in your biology. It is a feature, the functional reserve that allows these organs to compensate for gradual insults and maintain the metabolic stability your body requires. But that same functional reserve creates what I consider to be the most dangerous characteristic of organ dysfunction as a category of health threat. By the time the conventional tools of medicine detect it clearly, the window of easiest intervention has already closed. What remains is management rather than reversal, damage control rather than restoration. And for the majority of people who arrive at that window, the preceding years contain signals they did not know how to read. We are going to read them now. Beginning with the liver. The liver is the most metabolically complex organ in the human body, performing more than 500 distinct biological functions that range from glucose regulation and lipid metabolism to toxin clearance, hormone processing, immune modulation, and the synthesis of proteins essential to virtually every other system. It is also, by design, an organ that communicates its distress in ways that are consistently misattributed, consistently dismissed, and consistently addressed with the wrong interventions for months or years before anyone thinks to look at the liver itself. The first liver signal is one that most people have experienced and explained away entirely. It is a persistent sense of heaviness, pressure, or dull discomfort in the upper right abdomen, beneath the right rib cage, that tends to be more noticeable after meals, particularly after meals that are fatty, fried, or accompanied by alcohol. The liver itself has no pain receptors, but the fibrous capsule that surrounds it, Glisson's capsule, does. When the liver becomes enlarged or inflamed, as it does in response to fatty infiltration, sustained metabolic stress, or viral injury, that capsule is stretched. The result is a dull, persistent ache or a sense of fullness beneath the right ribs that most people attribute to indigestion, to a digestive sensitivity, to a heavy meal, or to muscle tension from sitting too long. It is none of these things when it is recurrent and unprovoked. It is the liver, enlarged beyond its normal dimensions, pressing against its own capsule, and it is telling you something important that antacids and positional adjustments will not address. The second liver signal appears not in the abdomen but on the surface of the body, and it is easy to notice and easy to misattribute. Persistent itching of the skin, particularly across the arms, legs, and torso, without any visible rash or allergic trigger, occurs when the liver's capacity to process and excrete bile acids into the digestive tract is impaired. Bile acids that cannot be efficiently cleared accumulate in systemic circulation and deposit in skin tissue, producing a pruritus that dermatologists treat symptomatically for months before its hepatic origin is recognized. A subtle yellowing of the skin or the whites of the eyes, not the dramatic jaundice of advanced liver failure, but a faint discoloration that you might notice in certain lighting or in photographs, occurs when bilirubin processing is compromised. Spider angiomas, small, spider-shaped blood vessel clusters, visible just beneath the skin surface, typically on the chest, neck, or arms, develop when the liver's capacity to metabolize estrogen is impaired, allowing estrogen to accumulate and drive the dilation of superficial capillaries. These are not cosmetic observations, they are hepatic signals written on the surface of the body by processes occurring deep within it. The third liver signal is one that appears on a blood test that most people have had, but few have been taught to interpret in the way that matters most. It is an elevated fasting triglyceride level. A finding that is noted on routine panels, is frequently described as mildly elevated without further investigation, and is almost never traced back to its actual biological origin at the point of care. When the liver is processing excess fructose and refined carbohydrate beyond its metabolic capacity, it converts that excess into fat through de novo lipogenesis and packages it into very low-density lipoprotein particles that are released into circulation as triglycerides. A fasting triglyceride consistently above 1.7 millimoles per liter is one of the earliest measurable indicators of hepatic metabolic stress, and if it has been creeping upward over successive annual blood tests, the direction of travel is as informative as any single reading. Your liver has been trying to communicate through the most direct measurable channel available to it. The question is whether anyone has been listening to what it was saying. The fourth liver signal is the one that most people find most surprising, because it does not obviously connect to the liver in the way that abdominal symptoms do. It is chronic fatigue, not the tiredness that follows exertion or a difficult week, but a persistent background heaviness that is present upon waking, that does not lift fully with rest, and that has become so consistent that it now feels like the baseline rather than an aberration. The liver's role in energy metabolism is extensive and largely invisible until it is compromised. It regulates blood glucose between meals through glycogen storage and release. It synthesizes the proteins and cofactors involved in mitochondrial energy production. It clears the inflammatory cytokines and metabolic byproducts that, when they accumulate in circulation, produce the systemic depletion that people experience as fatigue. When hepatic function is impaired, even subclinically, even in ways that leave standard liver enzyme tests within their reference ranges, the downstream effect on energy availability across the entire body is real, measurable, and felt every single day. The fatigue is not in your head, it is in your liver's increasingly compromised capacity to support the metabolic demands of a functioning human body. Now let us move to the kidneys and to the signals they produce when the silent decline of their filtration capacity is already underway. The kidneys filter approximately 180 liters of blood every single day, maintaining the fluid, electrolyte, and acid-base balance that every other system in the body depends on. They regulate blood pressure through the renin-angiotensin-aldosterone system, produce the hormone erythropoietin that stimulates red blood cell production, activate vitamin D for calcium metabolism and immune regulation, and clear the full spectrum of metabolic waste products that accumulate as a byproduct of normal cellular function. When they begin to fail, they fail quietly, their enormous functional reserve absorbing the decline long before any conventional measurement is significantly affected. But the signals exist, they are specific, and they are available to anyone who knows what to look for. The first and most informative kidney signal is one visible in the bathroom every day that most people never think to examine carefully. Foamy or persistently bubbly urine, not the transient foam of a forceful urinary stream, but foam that persists after the urine has settled, is one of the earliest detectable signs of proteinuria, the leakage of protein into the urine that indicates damage to the glomerular filtration barrier. Healthy kidneys retain albumin and other plasma proteins in the circulation. When the filtration membrane is damaged by elevated blood pressure, by diabetes, by inflammatory injury, by sustained metabolic stress, protein begins to leak through into the urine. And the foam you see is the visible surface expression of that leak. A 2018 study in the American Journal of Kidney Diseases found that even mild proteinuria, detectable on a simple urine dipstick, was associated with a 2 to 3-fold increase in the risk of progressive kidney disease and cardiovascular events over a 10-year follow-up. This is a signal that is free to observe, requires no medical equipment, and is available every single day. Most people have never been told it exists. The second kidney signal is a change in urination frequency, particularly an increase in nighttime urination, a condition clinicians call nocturia. In a healthy renal system, the kidneys produce less urine at night, allowing consolidated, uninterrupted sleep. This nocturnal suppression of urine production is regulated by antidiuretic hormone and by the circadian rhythm of renal function. When kidney function declines, this nocturnal suppression is lost. The kidneys produce urine at a more constant rate across the 24-hour cycle, and the result is waking once or more during the night with a genuine urge to urinate. This is commonly attributed to an aging bladder, to fluid intake timing, to prostate changes in men, or to light sleep. Sometimes those attributions are correct. But nocturia appearing or worsening in a person who did not previously experience it, particularly when accompanied by any of the other signals we are discussing, warrants a renal function assessment that goes beyond a standard creatinine measurement. The third kidney signal is oedema, fluid retention and swelling that appears in the lower legs, ankles or feet, is more pronounced by the end of the day, and is not fully explained by prolonged standing or sitting. The kidneys regulate sodium and fluid balance continuously. When filtration capacity declines, the kidney's ability to clear sodium efficiently is compromised, and fluid accumulates in the tissues, particularly in the dependent extremities where gravity concentrates it. Renal edema tends to be bilateral, symmetrical, and pitting, meaning that pressing a finger into the swollen area leaves a temporary indentation. It is easy to attribute to hot weather, to a long flight, to an uncomfortable pair of shoes. But when it is recurrent, when it is present most evenings regardless of activity level, and when it does not resolve overnight, the kidneys deserve consideration alongside every other explanation being offered. The fourth kidney signal is one of the most frequently overlooked because it presents as a symptom with an enormous number of more familiar explanations. It is a persistent metallic taste in the mouth, or a reduction in appetite, and a vague sense of nausea that has no clear digestive origin. When kidney filtration is compromised and the clearance of uremic waste products from the bloodstream becomes less efficient, those compounds accumulate at low levels in the circulation and tissues, not high enough to produce the obvious uremia of advanced kidney failure, but high enough to affect taste receptor function and gastric motility in subtle, persistent ways. A person experiencing this will typically attribute it to dental issues, to medication side effects, to a change in their digestive sensitivity, or to stress. They will not think of their kidneys, but the kidneys are thinking of them, sending through the only channels available the signal that their clearance capacity is no longer what it once was. Now let us turn to the heart and to the signals it produces during the years and decades of cardiovascular disease development that precede any acute event. Atherosclerosis, the process of arterial plaque formation underlying the majority of heart attacks and strokes, begins in the arterial walls of people in their 20s and 30s. It produces no pain, no fatigue, no reduction in exercise capacity for most of its duration. It does, however, produce signals in the behavior of the cardiovascular system under stress, in the subtle changes to how the body responds to physical and emotional demands, and in the measurable alterations to resting physiology that most people and most standard screenings walk past without recognition. The first cardiac signal is the most practically accessible and the most consistently underused. It is resting heart rate variability, the natural variation in the time interval between consecutive heartbeats that reflects the balance between sympathetic and parasympathetic nervous system activity. Heart rate variability is not the same as resting heart rate. It is a measure of the flexibility and resilience of cardiovascular regulation. In a healthy cardiovascular system, the interval between heartbeats varies slightly from beat to beat, reflecting the responsiveness of the cardiac regulatory system to the body's changing moment-to-moment demands. When the cardiovascular system is under stress, from arterial stiffness, from autonomic dysfunction, from chronic inflammatory load on the myocardium, that variability decreases. The system loses its adaptive flexibility. A 2017 study in the Journal of the American College of Cardiology found that reduced heart rate variability was an independent predictor of cardiovascular events in adults with no prior diagnosis, more predictive, in some analyses, than conventional risk factors including blood pressure and cholesterol. Heart rate variability can now be measured continuously by consumer wearable devices. If yours has been trending downward over weeks and months, that trajectory deserves attention and not simply an attribution to overtraining or poor sleep. The second cardiac signal is one that most people have experienced and rationalized away entirely, and that is a progressive, gradual reduction in exercise tolerance that is measured not against a population standard but against the individual's own prior baseline. Not becoming unfit in a general sense, but a specific contraction of what the body can sustain compared to what it could sustain 1 year ago, 2 years ago, without any change in exercise habits. A flight of stairs that requires more recovery than it once did. A brisk walk that produces breathlessness at a pace that previously required no conscious effort. An exercise session that leaves you more depleted than the equivalent session would have left you in previous years. This progressive ceiling contraction is one of the most important cardiovascular warning signals that exists, and it is among the most consistently normalized, attributed to age, to a period of reduced activity, to stress, to everything except the cardiac output decline that the research shows it most reliably represents. A 2021 study in the European Heart Journal found that self-reported reduction in exercise tolerance, measured against each individual's own prior functional capacity, rather than population norms, was one of the strongest independent predictors of subsequent cardiovascular events in adults between 45 and 65. The trajectory mattered more than the absolute level. A person who was moderately fit and declining was at substantially greater cardiovascular risk than a person who was moderately fit and stable. If your personal ceiling has been lowering, that is not an aging story, that is a cardiovascular story. The third cardiac signal appears during sleep, and it requires either a bed partner's observation or a wearable capable of detecting it. It is sleep-disordered breathing, specifically obstructive sleep apnea, the repeated partial or complete collapse of the upper airway during sleep that produces episodes of oxygen desaturation, cortisol surges, and cardiovascular stress across every night of sleep in which it occurs. Sleep apnea is one of the most powerful independent drivers of hypertension, cardiac arrhythmia, and accelerated atherosclerosis, and it is present in a substantial proportion of adults with cardiovascular disease, many of whom have never received a diagnosis because they do not identify as someone who has a sleep problem. They may not snore dramatically, they may not wake gasping, they may simply feel unrefreshed every morning, carry a persistent fatigue that they attribute to everything else, and have blood pressure that is slightly more difficult to control than their cardiologist would like. If your sleep is consistently unrestorative and your blood pressure is trending upward, sleep apnea warrants evaluation before any other cardiovascular intervention is prioritized. The fourth cardiac signal is one of the most informative available and one that the majority of people measure incorrectly and therefore derive almost no useful information from. It is blood pressure, but not the single reading obtained in a clinical setting that most people rely on as their cardiovascular health summary. Blood pressure in a clinical environment is subject to white coat effect, to the anxiety of medical settings, to the postural and physiological state of a single moment in a single day. What matters biologically is the pattern, the blood pressure experienced across the full range of daily activities, across morning and evening, across rest and mild exertion. Home blood pressure monitoring, conducted across multiple readings at different times of day over several weeks, provides a picture that a single clinic measurement fundamentally cannot. And what that picture frequently reveals, in people who receive reassuring clinic readings, is a blood pressure pattern that is substantially more elevated, particularly in the morning, when cardiovascular risk is highest, than any single appointment would have suggested. If you have a blood pressure cuff at home and are taking single occasional readings, you are not using the tool effectively. If you do not have one, acquiring and using one systematically is one of the highest value health investments available to you. Now, what do you do with all of this? Because the purpose of understanding these signals is not to create alarm, it is to create informed, targeted action taken at the right moment, which is now, while the organs retains the capacity to recover, rather than after the damage has become the kind that medicine manages rather than reverses. The first action is to request a genuinely comprehensive organ assessment at your next medical appointment, one that goes substantially beyond what a standard annual panel provides. For the liver, ask for a full hepatic function panel, including ALT, AST, GGT, and bilirubin, alongside a fasting insulin measurement, which is the earliest available indicator of the insulin resistance that drives non-alcoholic fatty liver disease, typically elevated for a decade before fasting glucose is affected, and fasting triglycerides as the most sensitive early marker of hepatic fructose processing burden. For the kidneys, ask specifically for an estimated glomerular filtration rate rather than creatinine alone, and ask for a urine albumin to creatinine ratio, which is the most sensitive early indicator of glomerular filtration barrier damage and which will not be ordered unless you request it. For the heart, ask for a high-sensitivity C-reactive protein, which quantifies systemic inflammatory burden and is the most informative addition to a standard lipid panel for cardiovascular risk assessment. Ask for a comprehensive lipid panel with LDL particle sizing rather than LDL cholesterol alone, and ask about a coronary artery calcium score if you are over 40 with any metabolic risk factors. It is the only non-invasive test that directly visualizes the arterial plaque that has been accumulating silently, and a score of 0 carries a genuinely reassuring prognostic significance that no blood test can provide. The second action is to begin monitoring your blood pressure at home with a validated cuff, taking readings in pairs at the same time each morning and evening for at least 2 weeks, and presenting the average to your doctor rather than relying on clinic measurements alone. This single change in how blood pressure is assessed frequently reveals a hypertensive pattern that clinic readings have been consistently missing, and addressing elevated blood pressure is one of the most powerful available interventions for protecting all 3 organs simultaneously, because the mechanical stress of chronically elevated pressure damages renal microvasculature, hepatic perfusion, and arterial walls through parallel and compounding pathways. The third action targets all 3 organs with equal directness, and it is available to you today without any prescription or specialist referral. Eliminate liquid fructose from your daily routine completely and structurally, not as an occasional reduction. Every sweetened beverage, including fruit juice in all its forms, represents a concentrated hepatic fructose load that drives fatty liver disease, triglyceride elevation, and the insulin resistance that compounds renal and cardiovascular risk simultaneously. Replace every sweetened liquid with water, sparkling water, unsweetened tea, or black coffee. A 2015 study in obesity found that this single substitution, sustained for 24 weeks, produced significant reductions in fasting insulin, triglycerides, and blood pressure without any other dietary change. 1 habit removed, 3 organ systems relieved of a primary stressor. The fourth action is to establish consistent sleep timing as a non-negotiable structural priority, not a preference that yields to competing demands, but a biological commitment treated with the same firmness as any other essential daily requirement. Consistent sleep and wake times across all 7 days of the week, a sleep environment maintained at a slightly cool temperature, and the elimination of bright screen exposure in the final hour before bed address the circadian disruption that independently accelerates dysfunction across all 3 organ systems. The kidneys lose their nocturnal filtration rhythm, the liver loses its primary repair window, the heart loses the sustained reduction in demand that allows vascular inflammation to resolve. All of this occurs every night that sleep is compromised, and all of it begins to recover within weeks of consistent sleep restoration. The fifth action is post-meal movement, 10 to 15 minutes of walking within an hour of eating, performed consistently after your largest daily meal. This single targeted behavior activates insulin-independent glucose clearance through muscle tissue, directly blunts the post-meal triglyceride and glucose spikes that drive hepatic fat accumulation and arterial inflammatory load, supports renal perfusion through the moderate cardiovascular activation that walking provides, and reduces the post-meal insulin demand placed on a pancreas that is almost certainly already compensating to some degree. It requires no equipment, no cost, no significant restructuring of daily routine. It simply requires the knowledge that timing matters and the consistency to act on that knowledge every day. Here is what I want you to carry forward from everything discussed today. Your liver, your kidneys, and your heart are not failing dramatically. They are failing silently in the specific technical sense that their distress signals are present, are real, and are being generated by real biological processes, but are not being received and interpreted correctly by the people experiencing them, or frequently by the clinical systems meant to detect them. The signals we have discussed today are not rare findings in unusual patients. They are the common, ordinary signals of organs under the ordinary stresses of modern life, stresses that are almost universally present and almost universally underestimated. You now know what those signals sound like. You know what to look for in your own daily experience, in your blood test results, in the pattern of your sleep, and your energy and your exercise capacity. And you know that the window of most effective intervention is precisely the period in which those signals are present, but the damage has not yet become irreversible. That window is open right now. What you do with it, the appointments you make, the tests you request, the habits you change, the signals you take seriously rather than explain away, is the most consequential health decision available to you. If today gave you the specific understanding to begin making it differently, please like this video and subscribe. There is considerably more coming that I believe will matter to you just as much. I will see you in the next one.